This is Chapter 5 from the textbook of Radiographic Positioning and Related Anatomy, the 11th edition. This is lecture over clavicle and AC joints. Both of those are found in Chapter 5 of your textbook. And we're going to begin on page 176 and 177. This image is figure 5.4 on 177. You can see that they are showing the shoulder girdle along with the sternum. When you look at the clavicle right here, the clavicle actually is a long bone with a double curvature. The clavicle has two ends and then a body, so really the only identifiable area is the acromial end of the clavicle, which articulates with the acromion process of the scapula to form the acromioclavicular joint or AC joint. And then you have the sternal end of the clavicle that articulates with the sternum and forms the sternoclavicular joint. Okay, so this is the clavicle. This is what we're going to be looking at first. And this picture is 5.4 on page 177. When we look at this in relation to a radiograph with the anatomy, you can see that this is the clavicle right here. If we look at this as far as labeling, this would represent the SC joint. This is between the sternum and the clavicle. B is the sternal end of the clavicle. C represents the body of the clavicle. D represents the acromial end of the clavicle. And then E is the acromion process of the scapula. Again, this is figure 5.5 on page 177 of your textbook. This next slide is not actually in your textbook, but it is a good representation of the three joints in the shoulder girdle. We just mentioned the sternoclavicular joint between the sternum and the clavicle. And then we have the acromioclavicular joint between the acromion process on the scapula and the clavicle. And then the third joint would be the scapulohumeral, glenohumeral, or shoulder joint. So again, this is not in your textbook, but it is a good representation of the joints in the shoulder girdle. If we look again, you've got labeled here sternoclavicular joint, scapulohumeral joint, acromioclavicular joint. So just placing that previous picture with the radiograph so that you can identify those same areas on an X-ray image versus just an anatomical drawing of that area. When we look at the movement types in the shoulder girdle, the scapulohumeral, glenohumeral, or shoulder joint is a ball and socket. We mentioned that before. That allows for greater freedom of movement. The SC joints and the AC joints are both planes or gliding types of joints. Okay, so not a whole lot of movement between the SC and the AC joints. Typically SC, we've talked about those before. When we evaluate a PA chest, we look at the joint space in the SC joints to make sure that they are equidistant, which tells us that there's no rotation taking place, meaning that the patient isn't slightly in an LAO or RAO oblique on a PA chest. If they're equidistant, then they're completely flat in PA. The views that are done on a clavicle, since it is a long bone, there are two views, and you have to demonstrate the joints at both ends of the clavicle. So the two views would be an AP and an AP axial. Remember that axial implies an angle of 10 degrees or greater. And these images are on page 203 of your textbook. So first you would start with the AP view, and this is figure 5.88 in your textbook. Recognize that this is going to show any fractures or dislocations of the clavicle, and you're going to be at a 40-inch SID to the wall bucky. You're going to be collimated to a 10 by 12 landscape. Your technique is just like it was for a shoulder. You're at 75 kVp at 4 mass on the grid. Okay, because most adult shoulders and clavicle area is thicker than 10 centimeters. So the patient would ideally stand with their back against the chestboard, standing straight, face forward, arms down by their side, and you're going to center the clavicle of interest to the actual wall bucky. On the AP, your central ray is perpendicular to mid-clavicle. Now recognize that you're not likely, since you're 12 inches across this way, you're not likely to collimate at all from side to side, but you will be able to collimate top to bottom since you are just looking at the clavicle. So your central ray is perpendicular to the mid-clavicle. As far as respiration on this, you're actually going to have the patient take in a deep breath and hold it. The reason for them inhaling deeply is to elevate the clavicles. So while most things we've talked about this month have been suspended respiration, this is actually taking a deep breath and hold it, and that'll help raise the clavicles for this particular image. The pictures are on the next page, but the other one that you would do after you took that, you would tell the patient to hold still just like they are. And then you're going to come in, and your AP axial is where you're going to angle the central ray, and you're angling it based on body habitus. So this one is a little bit different because most of the time we talk about the fact that if the patient is bigger, it requires more of an angle, and if the patient is smaller, it's less of an angle. But with this particular image, when the patient is larger, the angle is actually smaller because they are broader and wider, their clavicles tend to be elevated more than someone who is astenic. So the central ray angle on an AP axial, if your patient is hyperstenic, is 15 degrees cephalic. If they're astenic, it's 30 degrees cephalic. And if they're stenic, it's 20 to 25 degrees cephalic. So the range is between 15 and 30 cephalic angle, again to mid-clavicle. So smaller patient gets the most angulation, larger patient gets the least amount of angulation, and then stenic is in the middle. Now the images that result from the AP and the AP axial are on this next slide. So this right here is the AP. This references to figure 5.90 on page 203. Again, you have to visualize the entire clavicle in both images. You would not, I would disagree with four-sided collimation. I would say you're probably only collimating top to bottom, not side to side. Okay, so on the AP with the central ray perpendicular, you are going to visualize the clavicle as it normally would sit on the patient with no angle. And then the AP axial, you tend to see more of the clavicle above and elevated off the ribs. All right, so on the AP 0 degree, you have to visualize the entire clavicle, both AC and SC joints, along with the acromion process. Right. And the AP axial, again, you're getting the entire clavicle, both joints at either end, acromioclavicular and sternoclavicular. And ideally, you're projecting the clavicle above the scapula and above the second and third rib. And both of these, again, are done on inhalation. So take in a breath, hold it, and beep. Okay, so that is the routine for clavicle. It's both an AP and an AP axial. The degree of angulation is dependent on the patient's body habitus, and ideally Both images are done at 75 at 4, 40-inch SID, 10 by 12 landscape, and the patient takes in a breath and holds it before exposure. The second exam in this lecture is AC joints. Those are found on page 204. In AC joints, there are also two views for this particular anatomical area. We do AC joints both with and without weights. Ideally, this one's a little lengthy, because ideally when you're doing AC joints, you're going to have, in the best possible scenario, you would have both joints demonstrated on one IR. Okay, so ideally if you are doing both joints on one IR, then you're going to be at a 72-inch SID so that you can capture both of them. If that's the case, then you would be at 72 inches on a 14 by 17 landscape, and your technique would be 80 kVp at 15 mass. 80 kVp, 15 mass at a 72-inch SID, 1 IR, 14 by 17 landscape. If the patient is so wide or broad that they would not fit on one IR, then you are forced to do 4 separate IRs, because you need both joints. So you would do 4 separate IRs, and you would come into a 40-inch SID. If you're at a 40-inch SID, then your technique would be 80 kVp at 4 mass at a 40-inch SID. So if you're doing both joints on one IR, then you're going to end up using 2 14 by 17s placed landscape. If you end up having to do each joint individually, then you're going to do right without weights, right with weights, left without weights, left with weights. So you would end up doing 4 IRs at 40-inch SID, and your technique would be less at 40 than it was at 72. Okay? If you fit both of them on one IR, then your central ray is midway between the AC joints. Ideally in the book, it tells you that it's perpendicular between the AC joints and 1 inch above jugular notch. So I would say midline, 1 inch above jugular notch. And you basically tell the patient to stop breathing. They have no weights in their hand. They're simply standing with their back against the board, and you would make the exposure. Then you would tell them to stay still. You go back in the room, and you actually hand the patient sandbags to hold, not in their hands, but you actually would place the straps around their wrist. That way they're not holding the sandbags with their hands, but they're allowing the weight to actually pull down on the shoulder, and it'll relax and show any possible AC joint separation. Now, I would tell you, you would do without weights first, and then you would set everything up, give them the weight in their good hand or good side, and at the last possible minute, give them the weight in their bad side, and then have them stop breathing and make the exposure. If they have an AC joint separation, it is extremely painful. These weights are typically 5 to 8 pound weights. Okay, and they can be as big as 8 to 10 pound weights. If they're a larger adult, typically we use a 10 pound weight. If they're a smaller adult, typically it's a 5 pound weight. Another slide that kind of demonstrates how this is done a little bit better. You can see what I mean when the weights are on the patient's wrist, so they're not actually being able to hold the weight in their hand, but because of where it's placed, it's pulling down on the AC joints, and it will show any AC joint separation in that. Okay. Notice it says shoulder and or clavicle projections should be completed first to rule out any fractures, or you could take this without weights first, which you should, and check it before you apply weights to the patient. Right, so when they're standing with their back against there, this is what it would look like with the weights, and you would run and make the exposure. There is an alternative. If the patient cannot stand or cannot hold the weights like that, you can do this alternative view, which is on 205, where you have the patient lie on the table. You would place this IR. Honestly, this IR probably should be landscape. And then you would give the patient a sheet or something to go in one hand around the bottom of the ankles and up into the other hand. And when you go to make the exposure, ideally you would have the patient straighten out their legs and keep holding the sheet, which would allow the AC joints to be forcibly pulled on. I know that sounds silly, but basically you're having them hold on to the sheet, and then when you have them straighten their knees, when they straighten the legs, it pulls down on their shoulders, and then in theory, if there is an AC joint separation, it is going to be visualized on there. So this is an alternative. Honestly, it's very hard for a patient to inflict pain upon themselves. So sometimes this is, in theory, this is a good idea, but it doesn't always work. Another thing you could do is have a technologist stand at the end of the table and hold the patient's hands. And then when someone else is back there ready to make the exposure, you would pull on their hands, and then they could make the exposure at the time that you're pulling or stressing the AC joint. What those images look like on this slide here, you can see that this one says with weights, this one is without, so this one would be done first, this one would be done second. You can see the difference in position with the clavicle between the two images, right? And since they did both on one, the central ray would be 1 inch above jugular notch, midway between the AC joints. There is a little bit more anatomy on this side versus this side. So in theory, it should have been shifted just a smidge towards the right. But this one would just be standing with their back against the board, arms down by their side, and then they would apply weights. And you can see the AC joint, this is where they're looking in both of them. You can see that without weights, this one is a little bit open. This one, you can see the bones appear as if they're closer together. And then when weights are applied, this one separates slightly, and this one separates a little bit more. So I'm not really sure if there was anything wrong with that patient, but it does appear that this one separates a little bit more when weights are applied. Okay, so that is AC joints with and without weights. Now, I'm not sure about you, but recognizing I've heard the term an AC joint separation, AC joint tear, but not knowing what that looked like, I actually pulled this next picture and put it in here just to demonstrate that ideally this is a normal AC joint. You can see the acromioclavicular joint and the ligament. You can see the coracoromial ligament, the trapezoid ligament, the conoid ligament. You can see that that's how these typically are. And ligaments attach muscle to bone. No, I take that back. Ligaments attach bone to bone. Tendons attach muscle to bone. So these ligaments attach bone to bone. So the acromioclavicular joint and ligament is keeping together the acromion process of the clavicle and the clavicle, the acromial end of the clavicle. So this is normal. And then when there is AC joint separation, this is what happens. Typically those ligaments are either stretched or torn, and this is what we're trying to demonstrate in that actual image. So when you apply weights, there is separation between the AC joint. Looks painful. All right, so clavicle and AC joints both are in theory two images. Clavicle is AP and AP axial. The angle depends on the body habitus of the patient. And AC joints is with and without weights. Ideally, if you can get both joints on one IR, then you're doing it at a 72-inch SID. If you cannot, then you have to do separate images of each AC joint, both with and without weights, so a total of 4 images, and you would come into 40 inches and accomplish that. All right, if you have any questions or comments and concerns, please make sure to note them. Next time we meet in class, we can discuss and hopefully clear up any confusion you may have. I hope that this made it a little bit more understandable. Please refer to the positioning videos, and I will see you all very soon.